case numbers up to yesterday, I've put in this big vertical line, which is the 3rd of September, which is when Dido Harding first apologised for shortages in testing. So the numbers after that, I don't think we can assume they're an accurate reflection of new cases because people can't get tested, and there will be more cases than that. We also don't know exactly where the tests are, who's getting tested, how they're prioritising it. But despite all of that, they're still going up very steeply. So how else can we get a measure on how quickly cases are going up? The COVID symptom tracker app has 4 million users, and they have reported a doubling in cases. So they think there are now 62,000 people with symptomatic COVID as of the 15th of September, compared to 30,000 on the 7th of September. And I looked this morning and that's gone up to 69,000 again. That is a doubling time of 8 days. And the reason I want to highlight that is because the Imperial REACT study, which published last week, which tested 150,000 representative people across England, also showed an 8-day doubling period.
Can I just, Christina?
Yeah.
Sorry, there's. I don't know if it's just me, but your recording is out of sync. There's 2 of you speaking at the same time. Is this?
That's not me. That's someone else.
Is someone not muted? Sorry.
I think someone's not muted. Yeah. Someone must be watching it.
I think it's Alison Pollock.
Okay. All right. So the reason that matters is that the Imperial REACT study also showed a doubling time of 8 days from their data of a set of 150,000 people from the end of August and beginning of September. The ONS infection survey, which published today, also estimated new cases doubling from the week ending 3rd of September to the week ending 10th of September. So that's 3 now different measures of cases, all estimating an 8-day doubling time. And that compares to 4 days doubling time in March before lockdown. So we're going up more slowly than in March, but it's still quite quick. So where are the cases? This is the change in cases per 100,000 across the UK between the 10th of September to the 17th of September. And you can see many more areas of black. This is the northeast, which has obviously just been put under additional restrictions, more in central Wales and Northern Ireland. And in fact, it's now kind of becoming a case of there are more hotspots than there are not hotspots. And again, the Office of National Statistics, which published today, also saw increases in most areas, and they also said it was most increasing in the north, and actually London is on the increase. And what's really interesting is to look at the age of the cases. So this comes from Public Health England, and we can see here different age ranges going from 10 to 19 years old all the way up to people over 80. Time is across the top, and basically when it's greener, it's a lower rate of infection, and the more red it is, the higher rate of infection. And what you can see is that in July, there were very low levels of infection across the board. And then in August, it started increasing, mainly in the 20 to 29-year-old group, and then a bit in the 30 to 39-year-old group. And then from the second half of August to the first week of September, it started spreading to other age groups. So from the week ending the 6th of September, you're seeing actually, reasonably high rates across all age groups up to about 60. And again, the ONS survey, which published today, to the week to the 10th of September, also reported the same thing. They saw quite significant increases in children and adults under 34, and then smaller increases in adults under 70. So it is now spreading to other age groups in the population. Here's just an example of one hotspot, which is Birmingham. And you can see here quite a significant spike in cases at the end of August, first week of September. And then this is their new inpatients with confirmed or suspected COVID up to the 16th of September from their hospital dashboards of the 2 of the biggest hospitals there, University Hospital Birmingham and Queen Elizabeth Hospital. And you can see kind of quite big spikes last week, and then the days before. And so that's kind of consistent with it taking about a week after your symptoms come to get sick enough to need hospital. And the median ages of these people in hospital is 48 to 54. And that's consistent with the age thing that we saw just now, where it has now just started spreading into the middle-aged population. And they're the people who are more likely to need hospital, as are the older groups, but luckily it hasn't yet got to them as of the 6th of September. The CEO of the Birmingham hospitals warned that he thinks cases have doubled and they'll continue to double, and that we're in the foothills of an exponential growth phase. So now looking at new hospital admissions per day in England, we had 194 on the 15th of September compared to 84 on the 7th of September. And I picked those 8 days because, again, you're seeing this doubling time of 8 days. So it's all very consistent that we're seeing cases double, hospital admissions double in around 8 days. And that's kind of a hallmark of exponential growth. And I just want to spend 2 minutes just explaining what that really means. So exponential means that the increase tomorrow depends on how much there is today. So that's just like interest in your bank account. So if you have 10% interest, how much you actually get depends on how much you have. If I have £10, I'll get £1. If I have £100, I'll get £10. If I have £1,000, I'll get £100. So the more you have, the more it will go up. Linear means you get the same increase every day. So like someone just gives me £1 every day, and it doesn't matter how much I have. And the reason that epidemics are considered exponential, as long as there are enough people out there who are susceptible to getting sick, is because how many new infections you have tomorrow really does depend on how many people you have around to spread it. How many people have infections today will affect how many people will get infections tomorrow. And so that's why they're considered exponential. And so if we look at what that means, and just look at the last couple of weeks of hospital admissions, and I've started this from the 4th of September, which is where you start taking off. And I've just added an exponential growth curve that doubles every 8 days, like we've seen from the data, and a linear curve, which just kind of fit it to the first and last point. And that will just keep going. And for the first couple of weeks, you don't see much difference. But the thing with exponential growth is that it keeps accelerating as you get more and more cases. And so if we go out just a month into the future, you start seeing this big difference if you have this exponential growth with doubling every 8 days. And the reason that this is a bit concerning is that here, just under 400 admissions a day, that's where we were on the 18th of March. And that's next weekend. And where we were on the 23rd of March when we locked down was 1,100 admissions a day. And if we follow this red curve, we'll get there by the first week of October. Now, these are just estimates, right? People's behavior changes, restrictions might have an effect. And hopefully what they'll be doing is slowing down the period, so giving us longer before cases double. But if we're on this curve, then it means that by next weekend, we'll be at hospital admissions as we were in mid-March. So what does that mean? It kind of means, like we said last week, that we are balanced on a knife edge right now. This is a graph of modelled number of deaths over the next few months from Professor Carl Friston's group at UCL. And what they're doing is looking at what impact different levels of contact tracing will have on that curve. So they estimate that we're now at what they consider to be 16% efficiency of contact tracing, where that efficiency means how likely is someone without symptoms who has COVID to actually isolate. And that's kind of a measure of how good your contact tracing system is. And based on that, we are going to have, a kind of a secondary wave over October and November. If you improve that to 32%, but it takes you 8 weeks to improve it, it's too late, and you will not prevent this second curve. If we could improve it right now, you would prevent this second curve. So we're on this kind of knife edge where we have maybe 1 or 2 weeks to really try and improve contact tracing. But the good news is you don't have to improve it a lot. It doesn't have to be perfect. It doesn't have to be world-beating. It just has to be better. And that is doable. And you can do contact tracing without testing because you can contact trace people based on their symptoms. And again, other people in the group can talk more about that. And just, I want to say, it's not just about deaths. There's loads of evidence now that there are other issues with people who've had COVID, even mildly. This is adults, children seem not to have this, any issues so far. But obviously most people do recover completely, but there is a significant kind of minority who don't. And I think we have to acknowledge that and say that, we don't want anyone to get COVID. It's still a new disease. Second last slide now, just looking at the international context, this is from Barcelona Tech, and they looked at kind of 14-day cumulative cases and looked at Spain, France, and the UK, and they kind of noticed that France started increasing 23 days after Spain, the UK 24 days after France. And then so they pushed them all to start at the same time, and you have these identical trajectories. And I saw that yesterday and I was like, And it kind of reminds me of being back in March when we were on Italy's trajectory and a few weeks behind, and we could kind of see where we were going. And on the one hand, that's kind of depressing, but the good news is that we are behind, right? We do have time to step off this curve. And this is just some encouragement to show that you can do it. These are countries that have bent the COVID curve down without re-entering a national lockdown or having a national lockdown. Germany was increasing like France and Spain, but it's flattened itself off over the last few weeks. Japan and South Korea have bent their curves down. It's difficult, but it's doable. So just kind of to end, I'm not going to pretend that we're in a great place. We're not, right? There's a combination of a steep increase in cases. It's increasingly spread across the country and across different age groups. There are increasing hospital admissions, increasing ICU admissions, and we have a broken testing system, right? This is not a good situation for us to be in. And I will also say that understanding what's going on is hampered by the difficulty in getting the right data. Just trying to get all this data together is really hard. Wales, Scotland, and Northern Ireland all have much more transparent data than England. For instance, Scotland and Wales report test results by where they're tested, whether it's screening, whether it's in a care home, whether it's new symptoms, and so on. And it's really hard to know exactly what the data shows. And I just wish the government could be more transparent about the data that it's publishing. The Imperial REACT study estimated 8-day doubling time. That is now confirmed and consistent with the COVID symptom tracker app, the ONS survey, hospital admissions, right? That's in 4 independent pieces of evidence. And if that continues, our daily hospital admissions will be at mid-March levels by next weekend. And the modelling from Carl shows that we have 2 weeks to act. And we also know that countries who acted early have done best from March and April. So you act before you have a crisis. And that's kind of the problem with exponential growth, is that by the time you realise things are out of control, it's too late. So Independent Sage, we're proposing a set of measures to be implemented now to slow the spread of COVID, and Steve's about to go through that. And the government just needs to throw everything at effective improvement of test and trace, and it has to go local. And my final plea to the government is just they have to start their daily press conferences again. Where are they? What is their plan for the next week, for the next month, for the next 6 months? We just hear rumours, and then you have kind of late night restrictions coming in and not coming in. We need them to tell us what their plan is. And I'll stop there.
Thank you very much, Christine. Yet again, a model of clarity. I think we should get you to be giving, if not on behalf of the government, but at least explaining some of this information to the wider public. I think it'll be of great benefit. Okay, so as you say, what can be done? Before we move over to questions, I'm going to hand over now to Steve Riker, who's going to talk about Independent Sage's new consultation document for a 10-point emergency plan, which we're publishing today. Over to you, Stephen.
Okay, hi. Good. Well, hello, everyone. And this is a consultation document. These are suggestions from Independent Sage, but as every week, we welcome your feedback so we can revise and improve what we're doing. So, as Christina has laid out with great clarity, we are in a crisis. Infections are spiking, and not to put too fine a point on it, our testing system is broken. And the one thing that is absolutely clear is that if we do nothing, then the pandemic will soon run out of control. We'll be in a situation where we can no longer handle it with test and trace, and we will have to have a national lockdown. It'll become inevitable, and nobody wants it. So the real question is, what do we do, and what do we do now? Because if we dither, and we waste a week as we did in March, then we will sliver into a national lockdown. Now, the government tells us that on the whole, the problem lies with people breaking the rules. And in particular, there's been a lot of finger pointing and blame pointing at young people in house parties. But the ONS data which came out today, as well as showing the infection pictures, paints a rather different picture of why they are happening. Because it shows that if you look at adherence from ordinary members of the public, it is and it remains high. 93% of us are wearing masks. 81% of us are socially distancing. So people aren't breaking the rules on the whole, and people are doing what is asked of them. The problem is that some of the things that are asked of them are exposing them to infection. So again, if you look at the ONS figures, they show that we have gone up to 60% of us going to work. And the number of people working at home has declined from 40% to 20%. Or again, if you look at bars and restaurants, you find that over the last few weeks, the numbers going to bars and restaurants has increased in the case of restaurants from 10 to over 40%. Sorry, slightly under 40%. And there was research that came out from the States last week showing that those who were infected were twice as likely to have been to a bar or a restaurant in the last 14 days. So the problem lies not so much with the public doing the wrong thing, but with us being encouraged to do things which expose us more. So what can we do? And what we can do in our emergency plan is divided into two parts. On the one hand, there's what we can do now to limit exposure so people don't get infected. And then there is what we can do in the medium term in order to build a functional test and trace system so infections don't spread. So let me go into a bit more detail about those two things. What are the immediate measures? Well, they are, as I say, to limit exposure in all domains, not just at home, not just in terms of socializing with others. That's important, but it's only one of several domains. So we need to think about hospitality. And quite frankly, right now, we should be closing the pubs and restaurants indoors. Outdoors is a different matter, but indoors. In terms of work, as I say, 60% of people are going back to work. And a poll last week showed that 46% of workplaces aren't socially distanced. 38% of vulnerable workers are going to places where there are no mitigations. And so the problem is we're pushing people into places where they can get infected. That's got to stop. So we should work at home if possible. And if it is impossible, we need a robust system of certifying workplaces as safe. And until they're safe, we need to provide funding, a furlough scheme for workers so they don't lose out because of it. In terms of interaction with others, the problem about the rule of 6 is it allows 6 households to get together, and then different households getting together every day. And so in that way, you spread the infection. It would be far more sensible to have a limited number of households which can meet together over a period of time. And we propose limiting indoor, again, we stress indoor social interaction to a bubble of 3 households. Schools. Again, the government handed over responsibility to schools. It said, make classrooms safe, but we know where they're not safe. We know they're not socially distanced. And we need, as an emergency, to put funding into hiring more teachers and into hiring more space so that classrooms are socially distanced. And on top of that, already many thousands of children are having to socially isolate at home and losing out on education because they don't have the digital resources, the computers, the Wi-Fi to do their studies. So we need to make sure that every child in this country has got those resources, because you can't have educational equality with digital inequality. And finally, and this is absolutely critical, that we need people to self-isolate, but self-isolating isn't easy. And when people don't self-isolate, it's not necessarily because they're bad people, it's because they can't afford to do so, they can't practically do so. So we must, and this could be done by this government tomorrow, or indeed today, still time left today, to create an emergency fund to support all those needing to shield or to self-isolate. And that includes those who are trying to get tests through no fault of their own, can't get tests, and are now wandering around potentially infectious. So those are the things we can do immediately. As I say, they could be done tomorrow. What about the strategy for building a functional testing system? And again, it's been pointed out, we don't need a world-class testing system. We need one that works. We need one that beats the virus. The first thing is to go away from these centralized, privatized systems which have been proven not to work. We need to rebuild the testing system based on trusted local NHS and public health structures. We need to use those structures that are already in place and local. We need contact tracers who know their patch, who can go and knock on people's doors to trace them, because they won't always respond to phones, who use what I've learnt in a wonderful phrase is shoe leather epidemiology. And they know their patch, so they can trace where clusters come from, far more effective, as the figures show. We need clear messaging. And clear messaging that reaches all of the community, including minority communities, uses different languages, is culturally appropriate. We need to think more about asymptomatic cases and how we test them and who we test in order to make sure that our system is most efficient and protects the most vulnerable. And finally, we need to provide wraparound support which enables people to self-isolate. Now, this might seem, to those of you who are eagle-eyed and eagle-eared, like repetition of my point 5. And in a sense it is, but I make no apologies for that, because the figures that came out last week that were most shocking is that less than 20% of people who are asked to actually self-isolate, less than 1 in 5. And quite frankly, however good the testing system is, however many people we test and trace, if people don't self-isolate, we're wasting our time. And the reason why people can't self-isolate, again, is pretty obvious. A lot can't afford to. A lot of have got caring responsibilities. How do they get their food? And unless we provide that support, unless we help people to do the right thing, then it's not going to happen. So if out of these 10 points, there was one point that we could say, do this right now, I would say, I think many of us would say, set up a fund and fund people to self-isolate, because if you don't do that, you're wasting your time with a test and trace system. So I'll stop at that point.
Thanks very much, Steve. That's incredibly helpful. Very important points. We'll move on now quickly to questions. I'd like to invite Jonathan Ashworth, Shadow Health and Social Care Secretary and Labour MP for Leicester South, to kick us off. Over to you, Jonathan.
Well, thank you very much, and thank you all to the members of Independence Age. And I know many of you and do speak directly to many of you, and I've been following your deliberations collectively over many weeks now, and have read all your papers and watch many of your discussions on YouTube. So thank you very much for everything you are doing. But I cannot pretend that the first presentation I've just heard has not left us be hugely pessimistic and depressed, although it has confirmed my sense of what is going on. So my first question is, or my main question, I suppose, is I was reassured that I think it was Germany and Japan, I think you said South Korea, was able to bend the curve down. Is there any particular things that they did that we should be looking at here? Secondly, how much time have we got? Is this a matter of 24 hours, 48 hours, a week? Just a sense of time scale. And finally, I don't know if any of you stayed up late last night to watch me on Question Time. There was an epidemiologist on Question Time from Oxford. I'm sure many of you know her, whose view was almost that we're all being a bit sort of nanny statist, and flu is terrible and kills lots of people anyway. So why are we making a big fuss about this? And we're probably all building up immunity. So can you just reassure me, as given I'm not an epidemiologist, that my instincts were right when I disagreed with her on Question Time last night?
Thank you, Jonathan. Professor Carl Friston, I think since we're talking about modelling, maybe we should really come to you to address this.
Thank you. 3 great questions there. So let me try to answer the last question first about the role of population, or sometimes referred to as herd immunity. I think a specific answer to that is that population immunity is there in our community. It does afford a degree of protection for those people who have already been exposed. But more importantly, it provides a context that is augmented by things like social distancing, local lockdowns, a context that is exactly this knife edge that Christina described. And that's important because this knife edge speaks to the possibility of contact tracing having a material effect. So what I'm saying is it's probably best to think of all the factors that matter in shaping the course of the epidemic, that include things like herd immunity, that include things like social distancing and lockdown, all working hand in hand, creating this knife edge. And as Christina has shown, this knife edge provides a limited window of opportunity where contact tracing is going to have a material effect. It will, if implemented within the next week, in a way which we should speak to again, just to clarify what we mean by invigorating contact tracing, will in principle elude the peak death rates of about 50 to 60 in a few weeks' time. If we wait for more than 2 to 3 weeks, possibly 4 weeks, you will not be able to avoid those peak death rates and all the associated comorbidity. The reason that it's time sensitive is that we're falling off the edge of the knife now, today. So when you estimate the time constants, you can estimate the efficacy and the impact of an intervention and how long you have, what is the length of that opportunity. So it's not days, but I certainly think it would be within the next week. And what we're talking about here, I think it's useful to slightly divorce angst and worries about the performance of NHS test and trace from the thing that actually matters, which is the contact tracing. It's identifying those people who can spread the virus before they've started spreading it. So as Christina intimated in one little sentence, in principle, you could do it without any testing. You could just do it on clinical diagnosis. So what we really need here is this foot leather epidemiology. We need people doing detective work who can get out there, identify those people who are symptomatic and possibly PCR positive, and more crucially, everybody that may have infected them or anybody that could have been infected by them. There's forward and backward tracing. And then you need to monitor every few days, and you need to support them if they can't isolate. That's what is required. That's what we mean by foot leather epidemiology, the contact tracing. It's all about finding and supporting. It's not about testing. Testing will be very useful to get them out of isolation, but the finding and the isolated, the supported isolation are the key things. So the idea here is that we can do that if resources were redeployed to public health teams. You don't need a massive acceleration of public testing to do that. It's just a strategic redeployment. I'll just close by asking, why hasn't this been done before? I suspect it's because the government were told you have to have an 80% efficacy of contact tracing before it will work. The modelling suggests that is nonsense, that every little helps. And because we're on this knife edge, just doubling our efforts will be able to suppress or at least mitigate the next peak.
Thank you very much, Carl. Before we move on, Christina, can I just come to you quickly about the issue Jonathan raised about the Oxford epidemiologist talking about young people going out and getting it. I know this is something that you feel passionate about.
because I hear a lot of people saying, why don't we just get the young people out and get it and get immunity? Well, firstly, young people have been already disproportionately affected by lockdown. They're in much more precarious jobs, key worker roles, more likely to lose their jobs, more likely to be furloughed, more likely to be living in crowded housing without access to outside spaces, and in a recession. And now we're saying go out and get sick for us as well, when we don't know what the long-term impacts are, when we know that there's a significant portion of people with long COVID. And it will also disproportionately affect the disadvantaged groups, people living in multi-generational households, people who can't afford to isolate. Wealth becomes your best protection. And it just makes me really angry that we're asking this of young people. And who do they think cares for old people? Who do they think serves people in shops, delivers their food? I mean, it's just not feasible to do this kind of thing. Right, sorry, I'll stop there.
Thank you. I'm aware that several people wanted to come in, and I said at the start we'll try and limit just to 1 or 2 answers, but I know some of you are passionate. Can I just ask, anyone want to address the question about Japan and South Korea and what they've been doing differently? Has anyone got a sort of a quick, clear response to that part of the question? Carl, yes.
Sorry, yeah, I should have said that. So, the idea of local surveillance, good old-fashioned public health care, infectious disease control is exactly what the Germans invested in. That's why they've done so well. And you could make very strong arguments. Much of the model that I've just described is based upon those 3 countries. That's why they have been successful. Okay. And again, we ask, why hasn't that been done in the UK? And the answer, I suggested one answer.
Okay, I will come to all of you, make sure you all get a chance to say something, but I think time is running on. Jonathan, before you leave us, since we do have you here, it would be great to hear what you think about this consultation report and what you think the government should do about it.
Well, I think it's a great.
Do you think?
Yeah, I mean, there are really important recommendations, and I strongly agree with the points that have been made about contact tracing and a sufficient system of support for people to isolate. I mean, I'm actually sat here in Leicester, a city which was the first one to have localized restrictions, and we're still in localized restrictions. And we are a city like most of the UK's cities, where we have overcrowded housing, where low pay, 0 hours contracts is endemic. We have one of the highest child poverty rates in the country, significant deprivation. The idea that we have a huge number of people who work in precarious work and work in and have issues are exploited terribly in things like the textiles trade, which has finally got some prominence in the national media. The idea that people are going to be able to isolate themselves for 2 weeks after they've been in contact with somebody with the virus, without any decent financial support, is frankly for the birds. And I think fixing that ought to be straightforward for the government, and rapidly redeploying resources to public health teams to do the contact tracing is vital. As it happens, that because we were a city with restrictions, we were given extra support. For our Director of Public Health was given extra support, and he showed it could be done. But some of the problems he's facing, this might be something that IndySage wants to consider in the future, is that when he gets data from the national systems, it's a mess. He has to spend a day or two, or his teams have to spend a day or two cleaning it up and knitting it together with localized data. He could only, I think it's changed now, but initially he would only get data 48 hours after the Serco call center had tried to contact them, and then he would get the data. Well, that's no good. He needs it straight away, as you know. And it just feels to me like our local infectious disease control experts on the ground have had one hand tied behind the well, most of the time they've had 2 hands tied behind the back, but they still got 1 hand tied behind the back, and this needs fixing rapidly. So I totally agree with that point as well. And these are arguments that we've been making as a Labour front bench in the House of Commons. And we've been saying to them, put public health in control, put our NHS labs in control, invest in our public health infrastructure, invest in our National Health Service. Don't waste money on these big outsourcing companies who've got no experience of this and are making a complete and utter mess of it. And if we do go into these restrictions with all the horrendous implications of that, which have been outlined in the presentations, that is a failure of this government and a failure of their testing and tracing mess that they've made of it.
Great. Thank you very much, Jonathan. Well, let's move on. Our next question is from the press. Richard Horton, in fact, editor of The Lancet. Richard.
Hello there, sorry. Thank you very much indeed. I wondered when, this is really a question just for understanding, the data on which you presented Carl's data, is that being made publicly available?
Is anyone able to address that?
Those slides that you showed of Carl's data?
Oh, you mean Christina's?
Well, it was Carl's model, I think, that Christina was showing.
Carl, did you?
On the website.
Yes, so the specific graphics that Christina presents in the weekly meetings usually find their way into our consultation documents or reports, and they're available from the website. The underlying modelling and dashboards, both at a regional level and a local authority level, can also be accessed at a UCL website, and you can find a link to that in the Independent Sage website. The data upon which the modelling are based is freely available. It's not terribly disaggregated, and I just noted this problem of stitching together data from the government. There's a little bit of heavy lifting behind the scenes, but that is done automatically with open access software. So the data upon which the modelling that we've just been discussing is predicated is new cases per day and death by date per day from NHS trusts and local authorities.
Right, and then a question for anybody. It's been mooted this morning that a circuit break of a 2-week temporary lockdown is being seriously considered. Based on your analyses, do you think a 2-week lockdown would be an effective maneuver for achieving what Christina was intimating, that we need to act urgently now?
No, I don't. It would not be sufficient. Sorry.
Okay. Did you want to add to that, Christina? Or are you?
Yeah, just to say that a 2-week lockdown in 4 weeks is too late. I also don't think we need to go for full national lockdown. I think, one thing we've learned from the contact tracing is that transmission in England and other nations tends to be from pubs, restaurants, and household contacts. So I think we should concentrate on trying to restrict activity in those areas and continue working at home. We need to keep schools open.
Very good. Thank you.
Zubaida, did you want to add anything to that? Or?
Yes, completely echo what Christina said, which is the emphasis here needs to be to keep schools open. That needs to be the absolute priority. So we need to avoid lockdown. We need to listen to the messages that are coming out about find, test, tracing, isolating, and support.
Very good. Thank you.
Okay. Thank you, Richard. Okay, so the question is from Sophie Sweetman. Sophie there? Yes, I think.
Hello.
Hi.
Yes. My question is, amid widespread public concerns about our government not ruling out a COVID vaccine being possibly mandatory, with that having possible consequences as cold and flu viruses provide some immunity, how can we be sure that the government will create an informed vaccine distribution strategy, putting public health first by protecting those people you've talked about most at risk to stop the transmission instead of maybe maximizing drug sales profits?
Okay, anyone want to address that point? I mean, to Sarah Gilbert on the Life Scientific that was out on Tuesday. I just to plug something from Radio 4, but yes. Sorry, I'm. Oh, Gabriel, sorry, you had your hand up. Yes.
Yeah, I'll try and answer some parts of that. Some bits of the question would require some discussion and debate, I think. But the issue about putting together now a program to do the vaccination is extremely important, and to make sure we have the capacity. Even if we never have a vaccine, we need to plan now for having one so that we can do it efficiently and effectively. I, as a recipient with last weekend of the flu vaccine, I was deeply impressed by the way in which my general practice and many other general practices have handled flu vaccine this year. It took me about 60 seconds to be vaccinated from beginning to end. I think it's extremely efficient, and it will require a level of mobilization in terms of vaccination that we haven't seen for some considerable time in this country since since we had to do polio vaccine on a mass scale sometimes in polio outbreaks. That will be the last time I think I remember something like this. So it is going to be an enormous logistical challenge for us, and it will take a period of time. But you're quite right that it should be planned for now.
Thank you, Gabriel. Cameron, did you want to come in on this?
Yes, just a quick one. Just as Gabriel said, we have a plan for influenza vaccination. I think there are plans being made for flu vaccination if and when that arrives. There is the Q-COVID risk score that's being developed. It should be out soon. That will tell us who are at the highest risk if they get the infection in terms of hospitalization mortality. That will give us some sort of a prioritization risk tool so that we know who to vaccinate first, because we wouldn't be able to vaccinate everyone all at the same time.
Okay, there's lots of hands up still. Steve, I think you had your hand up first.
Yeah. A vaccine will solve nothing. It's people getting vaccinated that will solve things. And that's in many ways the biggest problem, because we're already seeing polls showing about half the population in various countries skeptical about the vaccine. And in many ways, the issue of trust and trusting government is absolutely central here. In many ways, the Cummings affair will come home to roost in the question of vaccination. Because when it comes to other things like lockdown or wearing masks, people do it because they are in many ways self-motivated. They do it sometimes almost despite the government. But we have to trust the vaccine, and we have to trust that it's safe. And therefore, the question of trust becomes absolutely center stage. And it's not only trust in the government, it's also trust in science. And in a sense, that comes down to the very ethos of Independent Sage. Trust in science depends upon scientists being open, listening to the public, because we don't have all the answers. We have some expertise, but we don't have all the answers, and being sanguine about the limits of what we know. So good open science and good open government are going to be absolutely critical to the trust that is needed for people to get vaccinated.
Thank you, Stephen. Tallulah, I know you wanted to come in as well.
Yes, thanks. It was just two points on that. We've been talking about the importance of the localized approach and a test and trace. And it's an opportunity really to think about that localized participatory strategy, not just for test and trace, but part of the comprehensive strategy of COVID control and prevention. So we should be thinking about that decentralized approach to include the context of vaccine implementation. And then the second thing is just the importance of learning lessons. Gabriel mentioned polio, learning lessons from other vaccinations of other diseases and other experiences elsewhere. And one of the critical lessons that we know is that it's vital that it is integrated as part of a comprehensive health service, so that it's not setting up a separate parallel system, because otherwise you stand the chance of having unintended consequences of neglecting other diseases. So I think those are just two quick lessons that we know from other previous experience that would be important to integrate here.
Thank you very much. Okay, so our next question is from Dr. Dominic Pimenta, who is author of Duty of Care, an account of working as an NHS doctor during those early months of the pandemic. Dominic, your question is about shielded individuals.
Yes, and obviously hugely honoured to be here and to ask a question. Thank you so much. I'll keep it very brief. Essentially, the cases now are about 6 times the level they were when shielding of extremely vulnerable individuals ended. And as you know, as cases move forward, that the prevalence in the community will only increase that risk. So I suppose the question for the panel is what should we be doing, advocating for now for those individuals in terms of guidance and in terms of also financial support?
Who'd like to address that point? Christina, and then Zubaida.
I mean, I think that it probably is time to ask people to shield again, and they need the support. They need financial support to do it. They need logistical support to do it, until we can get the testing and tracing system back up. I mean, all of this was avoidable. We haven't avoided it. So, I mean, that's the unfortunate thing. I mean, I think we can say that you can still meet outside. You know, I don't want to go back to that kind of completely on your own. I don't think that's where we need to go yet. But I think it is time for people to be more careful if they're in the shielding category.
Thank you.
And can I just add that I think one thing we're a little bit concerned about is there is more than a hint from government that the people that should be really making the sacrifices here are the young people and are those who are vulnerable and should be shielding. Oh, sorry, that's someone else speaking. And I think it's really important that the message is the message is that we all need to be making sacrifices and hard sacrifices in the next 2 weeks in order to avoid a full lockdown. It shouldn't be just the vulnerable, it shouldn't be just the shielding, and it shouldn't be just young people. And I think the government also needs to decide, as Christina said in her presentation, needs to make those hard decisions again about closing down pubs or making the decision about closing down indoor places much more. And those messages simply are not coming out. We don't have a government right now that is coming out with clear, consistent messages during the daytime. We just have them at nighttime. So those decisions need to be made, and it needs to be clear, and they need to be made now.
You're on mute.
Oh, for some reason I got muted. I didn't touch anything. Alison, sorry, before we move on to Fiona's question, did you want to come in on this?
I was trying to get in.
Oh, okay, let Susan get in. It's
fine.
Fine.
Sorry, Susan.
Yes, it's fine. No, just to add to what other people were saying in terms of what can we do right now for everybody, and not to lose sight of what I will label personal protective behaviours. To break that transmission of virus from one person to another. They sound boring, but we need to find new ways of getting it across to people that if people have touched surfaces that other people that they don't know may have touched, they need to sanitize their hands. If they are minded to touch their eyes or their nose or their mouth, they need to wash or sanitize their hands. At all points, they should be outside their house. They should be carrying tissues and a face mask so they can use them as and when they need them. And I think we need to strengthen our document and go back to 2 meters versus 1 meter as the default social distance. Because when you go down to 1 meter, that's about the distance that most of us are from each other anyway, if we're not intimate. And so the whole notion gets lost. We need a new campaign that works with communities and mobilizes communities to take ownership of how best to achieve this at scale and maintain it, because this is another key part of this equation. And if we don't get all these pieces going right now, as has been said, we are going to be in an incredibly dangerous situation.
Thank you. Alison, did you want to add something?
Well, clearly the most important thing right now is to get test and trace working. But there is an issue that GPs and primary care have been cut out of the system. And as Carl says, the important thing is to find symptomatic patients. And really there needs to be clinical integration. As Carl says, we'll never have enough tests, especially in winter time. And tests are only a diagnostic tool. the real way in which you make a clinical diagnosis, and that means bringing the GPs and primary care back into the system, especially when we're going to have lots of colds and coughs and flus, and that GPs and their primary care teams are actually sifting the people who they think they have symptoms, reporting that through the statutory notification system that has not and never been followed for suspected cases. And then that means that these people will be identified. You'll be using tests much more rationally and not wasting them. And in turn, you'll be able to self-isolate and contact trace further. So I would make a big plea, not just for public health to be built up, but resources to go back into the NHS labs, and NHS primary care, and a big call for clinical integration. There is nowhere else in the NHS where you can get a test without going through your doctor, except for a pregnancy test. This is an absolute nonsense, and it makes us very different from Germany and France, for example. So I think this has been a strategic error from the beginning, and it needs to be addressed. I'll stop there. I have another point on the rule of 6, but I'll come back to that.
Thank you, Alan. Okay, now over to you, Fiona Roberts. Sorry to keep you waiting, from BBC Radio 4. Fee.
Hello, yes, I'm the producer of BBC Inside Science. With the evidence growing that school-age children might not be presenting with the typical adult symptoms, fever, cough, loss of smell, but instead fatigue, headache, fever, sore throat and loss of appetite, how do they go about getting a test? I'm hearing more and more from parents of school-age children that they're being turned away for not having the qualifying symptoms.
Who would like to volunteer an answer to that? Alison, yes.
Well, I don't know where this evidence is coming from, but really you're raising an important issue, which is about the extent of transmission, infection and transmission in asymptomatic. And the studies really are very poor, and we need much better data on this, including on children. It's highly contested, but it does look as if a lot of studies are saying there's not a great risk, not so much risk of transmission, but then there are contradictory studies. So I think the best thing that we can do is focus on the symptomatic and symptomatic adult. It makes sense that they're the ones that will be transmitting most virus. And indeed, there's good evidence around viral load and CT thresholds. So I really think let's focus on the symptomatics and getting them screened properly and diagnosed properly through general practice and primary care. So let's just get the basics right. But we need good studies which are looking at the asymptomatic healthy population to see the extent to which they have infection or not transmitting. They're very variable. The big review has said only between 4% and 40%, huge spectrum, are actually carrying the virus, and a much smaller percentage are actually our risk of transmitting the virus from the asymptomatics. That's a systematic review by Paul Glazier that's out. I can put that on the web.
Thank you, Alison. Again, I'll try to restrict one answer to each question, but I know a lot of you have a lot to say. Gabriel, did you want to come in? No, okay. So Deanan, we haven't heard from you. Maybe you want to add something here.
Thanks for the question. Just to add to what Alison said, I think the question was around symptomatic children, and that there is, of course, a different spectrum of symptoms there. But for those symptomatic children, of course, there should be those criteria for testing, and I think it is important that they do be tested, because of course schools are sentinel areas for further transmission, and therefore controlling as much as possible to keep schools open is essential. And I think this speaks to what's come up before about ensuring that there is locality-based testing facilities, whether based in schools or in the community or linked to primary care, whatever it is. But I think it's a mistake, and it demonstrates our current errors that those children are not able to be tested. Thanks.
Thank you, Deanan. Okay, so the next question is from Ross Liddell. Is it Liddell, not Liddell? From the Evening Standard. Ross.
Hello, thank you very much. I wanted to ask, really, Alison slightly touched on this, but I wonder if anybody could answer essentially, what is the involvement, or why is the involvement of the private sector, why has that been so detrimental? Does anybody have a handle on what is actually happening in the Lighthouse labs? And does anybody have any sympathy for Dido Harding at present? Thank you very much.
Deanan, do you want to come in again? Yes.
Thanks for that question. I mean, we are where we are, and I think there are three sort of broad areas. This is my understanding of what's going wrong. First of all, of course, the separation and separate development of both the swabbing of individuals or home-based sampling through Deloitte's. There's the Lighthouse labs, which are administered in a different way. And of course, there's the data management, three separate things. And so the coordination of that has made it very difficult to respond rapidly to local changes in need. Secondly, it's clearly there's a staffing issue. This is my understanding, because of course initial staffing of Lighthouse Labs was to volunteers, and there's currently a call out, in fact, for longer 6 and 12-month contracts. So, and thirdly, it is the flexibility within the Lighthouse Labs, the inflexibility to modify techniques for pooling specimens to reduce demand on consumables. And I say it's not too late now, in order to overcome this, to develop a national consortium based around, as we've said, around NHS laboratories, Public Health England laboratories, as well as the private labs, together with Public Health. And I do think we need to rapidly try and convince Dido Harding to reach out to the community to help out.
Thank you. Okay, so now move on to another question from the member of the public, Sandra, who's going to ask something rather important about strategy for schools. Sandra.
Can you hear me all right?
You're very low. Is it?
Sorry.
Are you close enough to the microphone? Or?
I am really close.
Okay.
Sorry.
It's fine.
I'll try and speak up. Thank you for this opportunity and for the forum. My question is, I understand that the strategy for schools so far has been very much based on efficient track, trace, isolate system. Clearly that system is not currently in place. So should we at this point, or sooner rather than later, be putting in place alternative measures or preventative measures, taking shifts in school combined with homeschooling in or perhaps alternate weeks or something along those lines? What can be done sooner rather than later? The cases are increasing, the tests are not working, so other things need to be done instead, is my feeling. I would really appreciate the scientific perspective on this. Thank you.
Okay. Thank you, Sandra. I think if people didn't quite hear it, so the question is about the fact that we don't have a robust and efficient track and trace system in schools. So should we be thinking of another strategy, halving the number of children, combined with homeschooling? Is there something different can be done? Susan, yes.
Thank you. Well, two things need to be done. First of all is getting the community transmission rate down. That's the only way in which schools can be truly safe, because what happens is the virus will come in from the community into the schools and then be amplified. The second thing, and this is what this group has been saying throughout the summer, is that we need to be able to have social distancing at school, which means two things. It means more space, so taking over buildings that currently aren't being used to allow for more space. And it also means more teachers, so that there could be, for example, some shift systems. And there's no reason why the huge numbers of retired teachers in this country couldn't be brought back in the same ways as retired doctors and nurses were earlier in the year. So all of these things are things that can be done now. And if we are to keep the schools open, which I think is a big priority for everyone, then you're right, we need to be doing this now.
Great, thank you very much, Susan. Okay, we are running over, but we knew we were going to run over. Time for maybe a couple more questions. So the next one is from Karam Bales.
Hello there. Karen Bales, National Education Union. My first question was already asked about symptoms, so I'm going to do my second one. When a positive case is confirmed, schools are now often only being asked to isolate those sitting next to the positive individual, despite others being in the same poorly ventilated room for hours on end. What would an effective isolation strategy in schools look like?
Okay. People are thinking about how to address that. Who'd like to? Back to you again, Susan. Yeah.
I mean, it's a real problem because children will inevitably have touched the same surfaces, will inevitably have been breathing the same air, and so one can't guarantee the lack of transmission across that classroom or whatever the bubble is. So really, it comes down to, I mean, the principles of having as much ventilation as possible. But it does come down to what we were saying before about more social distancing and the very, very frequent disinfecting of surfaces and disinfecting of hands.
Stephen, very quickly.
Yes, I wanted to come back to this because it's one of the key points in our plan, which is all talk of schooling at home, of lessons at home, of shifts at home, mean nothing unless there is digital equality. Early on in the pandemic, a promise was made to give laptops to schools. It hasn't happened. And it is another thing we should be doing right now, because hundreds of thousands of kids are self-isolating. And if they've got the facilities, they can continue to learn. And if they haven't, they won't. And that will affect the rest of their lifetime. So a huge priority, I think, must be on a very simple demand, which is laptops and Wi-Fi for every student. It's something that can be done. It's got something that must be done if we're to maintain education for all our children and not create a massive problem of social inequality in the future.
Thank you, Stephen. And I think we've got time for one last question, this from Graham Brody. Oh, looks like Chris left us anyway. I think he probably maybe fell. Okay, so maybe Amanda Ferguson, who's a freelance journalist.
Yes, thank you for this. I'm just wondering, why do you think that the UK government appears reluctant to follow SAGE advice? And also, how frustrating is it as scientists to hear people like singer Van Morrison, who's just released some protest songs discussing COVID as if it's not a serious threat?
Gabriel?
Well, it's probably appropriate I answer that. First of all, Van Morrison has been social isolating for decades. It's not an enormous problem for him. And he also has the means, more than the means, to be able to look after himself perfectly well. And my clinical diagnosis would be grumpy old man syndrome, really. But why is the UK government not listening to SAGE? I don't know whether you mean, Amanda, independent SAGE or official SAGE, but there is a crisis about the government's advisory structure. That's something we've known for a long time now, and I think it's becoming more and more acute. My own personal perspective is that there remains enormous lacunae, an enormous hole at the center of all this, and that is that there is no practical public health experienced high-level input, and that is such a major gap. It is one of the failures, I think, that we entered this pandemic with. Of the 4 countries of the UK, only one of the chief medical officers had a background in public health medicine, and that's such a gap, and I think that is playing out now because that gap was reflected very strongly in the composition of the official SAGE committee, not happily in the composition of independent SAGE. And what the government really needs to do is listen to independent SAGE and start taking on board sound public health orientated but multidisciplinary and broad-based advice. Thanks.
Last word from you, Zubaida.
Well, I was going to say, it's one thing having the Prime Minister that doesn't plan and do detail, but it's another thing having a government that doesn't do plan and detail, especially in a pandemic. And we have been extremely concerned that there's no clear strategy from this government to deal with COVID-19, to deal with this pandemic, let alone a clear plan to deal with the next couple of weeks. And that needs to become really clear. And we really need the help of journalists and the public to put pressure on the government to not make late night 11 o'clock statements, by the seat of their pants in an evidence-free zone about what they're going to do next. We need a clear strategy and a clear plan.
Thank you very much. Well, thank you, everyone. Sorry, time always goes by so quickly. I think it's a relativistic effect. But we will be back next week. Thank you, all members of the committee, for your input. Thank you, everyone, for joining us. I'm sure next week we'll have a whole new load of issues that we have to grapple with. But until then, let's hope the government listens to some of these ideas and points that have been raised today. Thank you, everyone, and goodbye.
Thank you.
Thank you all.